Good morning, everyone. The topic for today's discussion is gingival surgical techniques. Now, what do you understand basically by gingival surgical techniques? Now, gingival surgical techniques means any procedure you do to the gingiva by which you are trying to scrape the gingiva or trying to resect the gingiva. That is a gingival surgical technique, actually. Now, when you do a flap surgery, what you're doing is you are reflecting a flap and you are exposing the bone. But here in gingival surgical techniques, you are not doing anything to the bone. You are not reflecting a flap. Probably in the milder aspect of a gingival surgical techniques, you are doing a scraping of the inner lining of the periodontal pocket, which is called as curettage. And when you have an enlarged or asymmetric or anesthetic gingiva, you try to reshape the gingiva by a process as gingivectomy. So these are the two processes that are involved in gingival surgical techniques, and let's go and discuss each of them. Now, before that, you have to know certain terminologies. These are things that probably you will be very familiar with. One is curettage. The curettage, as I mentioned before, is the scraping of the inner lining of a periodontal pocket. You have a gingival sulcus, the sulcular epithelium. So this sulcular epithelium will be usually inflamed in case of a periodontal pocket, and you are trying to remove all the inflammatory component of that gingival sulcus by means of this procedure called as curettage. Scaling, as you all know, you probably would have done about 40 scaling, and now you know what is used by means of certain specified scaling instruments. You try to remove all the hard deposits on from the from the tooth surface. That is called as scaling. Now, what is root planing? Now, root planing. Now, if you have a periodontal pocket, you have usually calculus and other microbial deposits attached to the root surface. By means of scaling, you are removing all those deposits. Okay, but the problem is the outermost layer of the root surface is called as cementum, and when the calculus or microbes get attached to cementum, the microorganisms that are present in this plaque or calculus will produce a lot of virulent factors or substances called as endotoxins, which may get adhered into the cementum. So even after we are removing the deposits by means of scaling, you have an outer layer of altered cementum. Now, if you have that infected layer of cementum, probably that will prevent the other tissues, that is the gingival epithelium and the gingiva, to come and attach the root surface. So what you do is, after scaling, take a curette and then smoothen the root surface. By smoothening the root surface, you are doing it very finely. You are removing the outermost layer of the cementum, the infected layer of cementum. That procedure is known as planing. Okay. Now, when you look at curettage, now depending upon the extent to which you do curettage, you can classify as gingival and subgingival curettage. Now, yeah, just by looking at the next figure here, this figure, you can know that what is gingival and subgingival curettage. Now, when you extend, Now, when you extend till this, you call it as this gingival curettage. You look here, you can see that this is extending to this region. So you are scraping only this part of the gingival sulcus. So probably epithelium and some part of the connective tissue you are scraping. So this is called as gingival curettage. But when you extend your curette far beyond to almost the crest of the alveolar bone, you are removing this whole of this gingival tissues along the whole of this inflamed tissue. This is called as subgingival curettage. Okay. Now you have to come across a term, or you should know a term which is called as inadvertent curettage. What is inadvertent curettage? Now, while doing scaling or group planing, unintentionally you are removing some part of the inner lining of the gingival surface. Now, this is not intentional, and this unintentional removing or unintentional curettage is known as inadvertent curettage. Now, when most of you, what I've seen when students do is they don't do an inadvertent curettage. In fact, they remove a lot of gingiva. We can call it as a gingivectomy also. Right? Now, what is the rationale of doing curettage? Now, the basic rationale is whenever you have a periodontal pocket, on one side on the tooth, you have a lot of deposits, hard and soft tissue deposits, while on the other side, that is on the gingival sulcus, you may find a lot of inflammatory component. It will be chronically inflamed. You have a lot of granulation tissues there. And within this granulation tissues, there will be a lot of microbial deposits. You may have dislodged calculus. And all this, what it does is, it can perpetuate or continue the inflammation. So basically, before probably doing a surgery, you want to clear off all the inflammation in relation to the gingiva. So you do a scaling and root planing first, and then you do a curettage by which the hard tissue is also addressed, and then later on the soft tissue is also addressed. So all the inflammation in relation to the tooth is being removed, and all the inflammation in relation to the gingiva is that means a curettage. So that is a rationale of doing curettage. But what is the present concept of curettage? In previous years, I think probably when the time when we were doing post-graduation, all the cases we were supposed to do curettage. But now the present concept is you treat the hard tissue, that is, you remove all the deposits in relation to the tooth surface. The soft tissue will automatically heal. So there is no need of doing any curettage. That is, you don't have to scrape the gingival sulcus, gingival lining. You remove all the accretions that are present on the root surface. It will completely heal. That's a thing. So there is no need of curettage at present. That is the present concept. You should know about curettage and what are the different ways in which you can do curettage. Now, what are the indications? Which all cases will we do curettage? Now, one is, as in some cases, some areas will be inaccessible. So in such cases, you may not be able to do a proper surgery in such areas. In such areas, you do curettage. And there are certain patients, like medically compromised patients, old patients, may not want to do a extensive flap surgery. So like to limit the procedure by doing, so that the inflammation is being reduced and you can try to control the disease. And then during recall visits, you find that the gingiva is inflamed, you can do a scaling, and along with that, you can do a curettage. These were the indications for which curettage was done. So what is a basic technique? Well, basic technique is, before any surgical periodontal procedure, the basic procedure you have to do is, one is scaling and second is root planing. So one, you have to do scaling first. Second, you have to do root planing. And you are scraping the inner lining of gingiva here. It's going to be painful to the patient. So you have to first give local anesthesia. And then you have to select a curette for doing curettage. Now, when you look at Gracie curettes, you have Gracie curettes from 1 to 14. You have 7 sets of curettes. And these curettes are designed in such a way that that curette is going to be adapted to the tooth surface. Okay? But the basic procedure here is You don't want the curate to get adapt to the tooth surface, but you want it to adapt to the tissue surface. So what you do is, if you are using a curate to root plane the mesial aspect of a tooth, for curettage, use the same curate on the distal gingiva. So that is a simple one. Like for 13, 14, curate is usually used on the mesial aspect of the loss. Right? So, and 11, 12 on the distal surface. No, Gracie curate 13, 14 is usually used in the distal surface of molars. But when you do a curettage, you're not applying in the distal surface, you're applying the mesial surface. So that becomes opposite for the 11 and 12 curate. So you don't adapt to the tooth surface, you adapt to the opposite gingiva. That is the basic. Now what you do, you insert the instrument into the gingival sulcus so that the most apical aspect is being adapted to the gingival sulcus, and then using a horizontal motion, and the outermost aspect of the pocket is supported on the external surface. Now this is how you do a curettage. You can see look here. What you can do is this is here. You adapt, you place the curate here, and on this aspect, outermost aspect, you place your finger. You support it with your finger, and then a horizontal motion is being carried out by which this tissue is being scraped. That is basically how we do a curettage. Now, subgingival curettage. Subgingival curettage is the only thing is, you have to extend it a little more down, almost to the alveolar bone. Okay, but the same thing. The procedure is the same. You just take a horizontal motion, remove that tissue, then clean that area well. You may find some more remnants of calculus on the root surface. Again, root plane that area, flush that area, apply with saline, and then just with your finger to digitally press that area. And if you feel that the tissues are spread or it's not coming in close approximity to the root surface, probably you can do a suturing, or it can be. Suturing and pack are optional here. You don't have to do it in all the cases of that. It is optional. So that is a basic procedure for doing a curettage. Now these are the steps. You can see that you engage the most apical aspect, just pull it up, and then you can see that the whole inflamed there was. Then with your finger, just adapt it to the tooth surface. It's not getting adapted, probably you'll have to do the suturing and packing. Now, what are the other techniques? This is the standard basic technique that we used to do. Now, there are other techniques by which you can do. One is known as the INAP, or the excisional new attachment technique, which was put forward by Naval Dental Pops in the US. Then you can use ultrasonics for curettage, use caustic drugs, chemicals for doing curettage. Nowadays, you can even use laser for doing curettage by a procedure called as a LANAP, laser assisted new attachment procedure. So what is INAP, or excisional new attachment procedure? As I told you before, it is developed by the US Naval Dental Corps, and it is a definitive subgingival curettage which is performed using a periodontal knife. Steps are, as I told you before, scaling and root planing has to be completed. Review the patient later, give local anesthesia. Then what you do is, here you are not just scraping the inner lining of the pocket. What you do is, you are using a periodontal knife, or you can use a BP blade and handle, number 15 BP blade and handle, and you put an incision which is known as internal meval incision, extending from the gingival margin towards the tooth surface, and it has to be carried out both proximally, both buccally and lingual. I'll show you that. Now this is, So in Curettage, what we did was we inserted this Curettage and pulled this tissue out. Now here you are putting an incision like this, this inflamed tissue. So you put an incision like this in such a way, and then what you do is after putting an incision, you insert your curette and then take out this tissue. And whatever deposits are present on the root surface after that is being removed, area is being well flushed, and then again you adapt this tissue towards the root surface. If it is not getting adapted, probably you can do a suturing and packing. So this is a remove the excised tissue with curette and replane all the exposed cementum. And if at all there is any connective tissue that is attached to the root surface, try to preserve that, approximate the wound edges, and if they don't mean passively, place a suture and give a pressing. Now you can do curettage by means of ultrasonic curettage. Only thing is you need specialized tips for that. Now, what does the ultrasonic vibration result in? Ultrasonic vibration will result in disruption of tissue continuity. It will lift up the epithelium. It will dismember the collagen bundles, and it will alter the morphological features of the fibroblast. So these are the four different functions or four different effects of ultrasonic vibrations. And you have different ultrasonic tips of scalers that are available in the market. One is known as a Mohs scaler, and the other is a rod-shaped ultrasonic. These are the common instruments. So these are used. Again, drugs can be used. You apply some little bit of drugs into the gingival sulcus, and this will actually cause sloughing of the tissue, and you can remove the inflamed tissue. But what is the problem? Can you control that? Can you control the extent of these caustic drugs on the gingival tissues? You can't control it. It is a problem. I mean, it was used before. Now it is not used. It is a historic concept, and mainly we use sodium sulfide and alkaline sodium hypochlorite. Sodium sulfide and alkaline hypochlorite, which is known as antiform, and also a few phenols have also been used. So these are the caustic drugs, but it is of historic importance. It is not now used. It is discarded. Now, how does healing take place after scaling and curettage? Now, you do scaling or you do curettage immediately within the gingival sulcus, there will be complete healing of blood. You can see that you just touch that area, do a scaling, and you can see that in the tissues there is dilated capillaries and a lot of PMNs, that is neutrophils, appear shortly in the wound site. And there is slow progression of proliferation of granulation tissue, and epithelium starts migrating from the edges of the wound. And epithelialization occurs by about the first week, that is 2 to 7 days. And junctional epithelium starts to be formed by the 5th day. And almost you can see that healing takes place by the 3rd week, that is the 21st. By the 21st day, you may find some immature collagen fibers attached to the java. So this is how the basic steps of healing. So blood fills up, that converts into granulation tissue. There is an intense inflammatory response that takes place. The epithelium migrates from the edges, the connective tissue fibers starts forming, and you can see some amount of fibers by the 21st day. So this is the first part of gingival surgical techniques, that is gingival curettage. So we'll stop with this, and I'll take gingivectomy as a separate class.